Good morning. Hi there. My name is Leanne Jeppa, and I am the owner and founder of Nourish Lactation Consulting. So today's IG live chat is going to cover the topic of breastfeeding and reflux. But before we get started, I think I'll just do a quick introduction as people are joining the live event. Hi, everybody. So I am the owner and founder of Nourish. Nourish was created in 2008. I became an IBCLC, which is an international board certified lactation consultant, in 2007. And I had worked in the postpartum world since I graduated from nursing school in the year 2000. And I found from supporting breastfeeding in the hospital that there was an additional need for in-home support for women in their comfortable home setting without the need to have to take their baby to clinic. And over the years, I have supported women still in hospital as well as through in-home support through Nourish. And the company has grown exponentially over the years. So I thank you all for your support. So breastfeeding and reflux. The reason why I chose to host this live event today was that I have noticed in the recent months over my practice that I've been asked to consult for fussy feeding, moms that aren't sure if it's reflux. If it is reflux, how do we manage this? The bottom line is when you're dealing with reflux, it can be very challenging to a feeding relationship, and it can, it does become very stressful for both the mom and baby. And naturally, as parents, we are a little bit reluctant to consider medication for our infants, but sometimes medication is the answer to returning a breastfeeding relationship to calm. But first of all, let's just go back to the basics. We're going to talk a little bit about the physiology of the infant gut and what it actually means when an infant does have reflux. So we have our stomach, and then we have this long tube that connects our stomach up to our throat and our mouth, which is the esophagus. So when your baby is drinking your milk, the milk goes down into the esophagus, into the belly. Infants naturally have immature digestive systems with little flaps or sphincters, and for some babies those little flaps or sphincters are looser. So when a baby has reflux, that little sphincter that goes from the stomach up to the esophagus can be loose, and that milk plus the stomach acid can move up, and it can cause pain, discomfort, inflammation, and then can lead to feeding issues. So if that is of a concern, then we need to do some investigating. So when I'm working with a family that potentially thinks that there is some reflux, these are the questions that I ask for in terms of determining what the signs and symptoms are that they're experiencing. So sometimes we see just fussy feeding. Babies are squirming, they're arching their back, they're bending, they're turning away from the breast. This often happens shortly once the feed has started. I've been finding recently that moms tell me it's usually around the 5-minute mark that the baby will pull off, starts arching, crying, is uncomfortable, and then might refuse to go back onto the breast. Sometimes if the mom has a very fast milk letdown, we can see this happening as soon as the baby attaches, because babies are very smart little people, and it's almost like they know, they're anticipating that the milk is going to flow fast, it's going to flow furious, they're going to have to be very on their A game, coordinating suck, swallow, breathe, and it can be their bellies fill up faster and can cause discomfort. So if we have that, fussy feeding, pulling on and off, or around the 5-minute mark, they refuse to feed, those could be potential signs of reflux causing an issue. Some other things that we might see. So after the feed, the baby's just very uncomfortable, just very fussy, very squirmy, doing a lot of arching. You go to change your baby's diaper and you're lifting their legs up to clean their little bums, and they're getting even more uncomfortable due to that additional pressure on their belly. Sometimes and often we do see more spit up just due to those loose flaps, those loose sphincters, more milk coming out, and it's more acidic milk coming out that's causing discomfort. Sometimes their voices do become hoarse from the milk refluxing. That increased acidity does cause some inflammation in their throat. So their little cries, their little voices do become hoarse. Sometimes we'll notice, we call it dry swallowing, where it seems like the baby's chewing or like trying to push something down. Sometimes we'll see even more forceful spit ups, a baby that was sort of our classic, call them happy spitters, because let's also remember babies spit up, and there is also a normal degree of spit up due just to that natural immature digestive system. But if your baby is spitting up more frequently, seems to be more uncomfortable, and now perhaps we're having issues with weight gain, perhaps the weight has slowed down or your baby's beginning to lose weight, those are things that are also of a concern to us. Let me just check my list here and make sure. Oh yeah, so coughing. Sometimes coughing or gagging, if that milk is refluxing up, you might see some increased coughing or gagging. Sometimes we'll also see just refusal. They will just refuse to feed altogether because they are so uncomfortable. Another thing we also see is snacking. Our babies become snackers. I often find babies with reflux, they reach a certain capacity in their belly when they're feeding. And once they've hit that capacity, they're like, no more. If I start to fill up my belly even further, that milk's going to come up and it's going to cause pain and discomfort. So no thank you. So they tend to become snackers, shorter feeds, but then feeding frequently. Another thing I've also noticed is that moms report feeding is often really, really difficult, challenging during daytime, but their babies tend to feed well when they're sleepy or nighttime. Overnight, the feeds seem to go off without a hitch, or not as challenging as they can be during the daytime. So those are some signs and symptoms. So when I'm working with a family, I kind of go through all those questions to rule out, are we actually dealing with reflux, or are we dealing with something else? Sometimes fast letdown, oversupply can also present with some of these signs and symptoms. So we manage that. And sometimes we have both issues going on at once: oversupply, fast letdown, and a refluxy baby. So we got to do a bunch of management and care and concern for these families. So how can we manage? So obviously when I come to do a consult, I observe the entire feed. I need to see what the baby's behavior is, how the mom is latching baby, how is her milk flowing, and in order to create a plan to support the feeding relationship. So if I feel that there is reflux, often my first concern is preserving that feeding relationship. So we want to make sure that the mom feels supported, and that we start with encouraging her to always be respectful of the baby's feeding cues, because we really don't want to run into any issue along the way with aversion, right? Making baby latch if the baby's saying, no, I can't do this, I'm not feeling comfortable to do this right now. So if the mom, let's say she does have an oversupply, there's lots of milk, sometimes I will recommend pre-expressing, taking off a little bit of milk first, just so that initial letdown isn't as forceful, so that the baby can manage the flow a little bit better. Positioning is also very important. So when babies are feeding, we always want to ensure, where's my little baby doll? Oh, she's in the vehicle because I was just doing a prenatal consult. So we always want to ensure when babies are feeding, head and shoulders are well above their bum, head up, right? And that also aids with digestion. When we think about our digestion process, we are going to feel better. Nobody likes to eat, lying down, lying flat, lying on their back. So you always want their head and shoulders higher than their bums. So for me, the feeding position is really, really important. So keeping that head higher is great. Sometimes if that milk is flowing fast, we need to have mom lean back a little bit. Now, if the baby is gulping and seems to be getting challenged by the milk flow, we implement a technique called external pacing, where you delatch the baby from the breast, but you keep the baby right near the breast. You're not bringing baby up to burp and move around. It's just a quick delatch, few seconds to catch breath, latch on again. And sometimes we have to repeat this multiple times until the baby shows better control of the milk flow. The idea is that we want the feed to be more of a marathon, slow and steady, versus a sprint. Gulp, 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 fast, 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 filling up that belly with gas, air, increasing the potential for reflux. And then babies typically will have a shorter feed just because they're exhausted after a few minutes, because they haven't been giving those opportunities to pace. and slow things down. I do see a question there about a tongue tie. We can talk a little bit about that afterwards, but yeah, tongue ties can definitely lead to all sorts of feeding issues, and there's definitely research that links tongue tie with reflux. So during an assessment, when I'm working with a family, I will always perform an oral assessment to check baby's tongue function and ensure that a tongue tie isn't contributing to any feeding issues. So sometimes, you know, we have to problem solve. It's not always black and white. It's not always, it's because of this that we're seeing this. Sometimes it's multiple factors, and we do have to look at the whole story in order to come up with a plan to support the family and help them achieve their goals. So those are some things that we can do with positioning. If the baby does typically drink quickly, I do recommend frequent burping. So after a few minutes of feeding, you delatch your baby up over the shoulder or supporting under the jaw, leaning forward, gentle pats on the left side of their back, bearing in mind our stomachs are here on our left side. So when we're burping, we want to be patting on the middle left part of the baby's back. I do tapping and rubbing up to help move the air up. I usually suggest burping for 1 to 2 minutes. If no air comes up, return to feeding. I do encourage good drainage of the first breast before offering the second. So for me, anything less than 10 minutes on one side is not, I like my moms to feed for, if they can, at least 10 minutes on one side or until the breast is soft before switching to the other breast. But often babes with reflux might not even make it to the other breast because they're getting uncomfortable with reaching capacity on the one side. After feeding, this is when things can get a little dicey. So if a baby does have reflux, we want to encourage keeping the baby upright for at least 20 minutes post-feeding. So I don't recommend changing that diaper right away. Putting your baby flat on their back, pulling their legs up, putting pressure on the belly can cause the milk to reflux. I do usually suggest trying to change their diaper on their side. So putting them either on their left or right side, gently pulling the legs up. It's not putting as much pressure on the belly and changing them that way, and not having them in too many positions where they're slouching and putting increased pressure on the belly. So those are some things that we can do to help manage the breastfeeding. If we find that through our conservative measures, the feeds just aren't improving and the symptoms are actually worsening, then I'll say, okay, now it's time to consult your physician, either your family doctor or your pediatrician, to discuss your concerns and to talk about the possibility of an anti-reflux medication to help with the pain and discomfort. Now, one thing we need to bear in mind is that if a medication is prescribed, the medication does not stop the spitting up. It doesn't stop the milk from rising from the stomach up into the esophagus. All it does is it helps to neutralize the stomach acid so that when the milk does rise, it's not causing pain or discomfort for the infant, so that they are able to continue feeding more comfortably and hopefully for a little bit longer and more efficiently. So there are the most commonly prescribed medications are called PPIs. So PPIs, it's a proton pump inhibitor or an H2 blocker, and those basically help to lower the amount of acid in the baby's stomach. And like I said, it just helps to heal the lining of the esophagus, so it decreases that inflammation, and it doesn't happen overnight. If there is quite a bit of inflammation, sometimes it can take days or a week or longer for that inflammation to settle before the family starts to see feeding improvements. I've worked with lots of families who notice within a day, they're like, oh my gosh, this was amazing. I can't believe we didn't try this sooner. Their baby's improvement happens right away. For some families, it does take a little bit longer. Some other things we need to consider with medication. So the most commonly prescribed medications in my neck of the woods here are omeprazole, which is Losec, or Prevacid, lansoprazole. The Prevacid is usually prescribed in a fast tab, which a lot of the pediatricians I work with like, because the medication, the liquid form of the medication is nasty. It's sour, it's bitter. A lot of babies do not like the taste and end up losing more than what they're actually taking in, and then we're not dosing appropriately. So with the Prevacid Fast Tab, it's a little dissolvable tablet that you just stick into the corner of baby's mouth and it dissolves, and then we're ensuring that they're getting the full medication. But of course, these are conversations that you need to have, the family needs to have have with their primary healthcare provider to decide what medication is appropriate. The dosing is also very important. I work with lots of families. The dosing is incorrect. The dosing is too low, or the dosing has not been adjusted as the baby grows. So as the baby gets bigger and gains weight, the dose does need to be adjusted to match weight to ensure that it is dose appropriate. The other thing we have to consider is when we're giving the medication, it's usually recommended to give in the morning, approximately 30 to 60 minutes before a feed. That can be really challenging with a breastfed baby. When baby wakes, they want to eat. Waiting 30 minutes is not always ideal. But if you can give the medication before a feeding, ideally 15 to 30 minutes, that's going to achieve its maximal effectiveness for the feeding. The other thing too is the medication has to be refrigerated, or the omeprazole does. I recently worked with a family who, first of all, the medication wasn't dosed properly, totally not their fault, but they didn't realize that it had to be kept in the medication or that it needed to be given prior to feeding. So once some of those little kinks got worked out, things did improve. So medication can be very helpful. I've worked with lots of families that notice big improvements. The medication, families want to know, how long does my baby need to stay on? I usually recommend 2 to 3 months. Just because you see improvements, it doesn't mean that now the issue has resolved. Sometimes we have to wait a little bit for that GI, those little sphincters, those little flaps, for the muscles, the smooth muscles, to mature a little bit in order for them to be able to close properly and not cause some of that reflux. So sometimes it is discontinued shortly after the baby begins solids, and sometimes, depending on the severity of the reflux, the baby does need to stay on it ongoing. Usually by, I would say, a year, most infants have been able to stop the medication. So that's basically breastfeeding and reflux. The other thing, circle of support, that I mentioned sort of in the outline. These families need a lot of support along the journey. So one thing that I always provide my clients is sort of that ongoing technical support. I'm on my phone pretty much 24/7, but a lot of the time to troubleshoot. If a family, if they have a question, a concern, they just want to run something by me, having that support along the way, I find, is really, really important to help the family achieve their feeding goals. And just to be able to troubleshoot something, ask a question, help give them some reassurance, really will help to preserve the breastfeeding relationship. And I always want to ensure that I have happy mamas, happy babies, and I do my best to support. And honestly, if there's something that I feel is out of my realm, my scope of practice, if I'm like, I'm not sure what's going on here, I refer, to local breastfeeding clinic. I'll refer, family back to their family doctor. I will also refer families to the eating, feeding, swallowing clinic at the Alberta Children's Hospital if there are more complex feeding issues going on that need to be addressed. So I really try to provide them with a well-rounded circle of support to help them achieve their goals. Well, that is about it for now. So if anybody has questions, Danielle, I hope I answered your question about tongue tie. Having similar symptoms, how do we distinguish between the two? Oh, sorry, one thing I did forget to chat about that was in the outline was food sensitivities. Sometimes while we're working through a reflux diagnosis, we will often ask mom about her diet, about the baby's bowel movements. Have there been any changes to bowel movements? Because often it can be a little bit of an overlap with reflux and food sensitivities. For infants, the most common food sensitivities are dairy. So cow's milk protein sensitivity is very common. Then we go to soy, and then sometimes eggs, corn, or beef. But usually the most common one that we will often ask a mom to eliminate while we're working through a reflux diagnosis is cow's milk protein. And we have to remember that cow's milk, dairy, is hidden in a lot of foods. So if there haven't been any obvious changes to the bowel movement, so things that we're looking for changes would be mucus. I know it sounds disgusting, but if it looks like your baby just kind of blew their nose into the diaper, mucus is a sign of a sensitivity, typically dairy. Or if we see flecks of blood, then we know for sure we're dealing with often a cow's milk protein allergy. So we'll ask mom to do a dairy elimination. If it's sort of a soft, like I'm not sure 100% if the baby is sensitive, I'll ask mom just to limit or just to cut back on the obvious sources of dairy, your milks, your cheeses, your yogurts. If there is sort of like a hard yes to a cow's milk protein sensitivity, then we have to be very particular and very specific about reading labels, because dairy is hidden in a lot of foods and some babies are quite sensitive to that. And then if we're not making much progress, then we'll say, okay, let's cut out soy. And then the next step is eggs. Some babies are definitely more sensitive, and we do often see reflux with those sensitivities go hand in hand. Okay, does anybody else have questions? So Danielle, similar symptoms, how do we distinguish between the two? Again, it's problem solving. It's looking at the whole feeding experience, the journey, taking a detailed history, observing the entire feed, doing a complete oral assessment to put all the pieces together to determine what's going on. Okay, I see we got another question here. My baby has been on omeprazole. We had his tongue, lip tie released and have noticed many positive changes in feeding now. Still noticing lots of back arching when being cuddled to sleep. Normal. Yes. So back arching can also just be your baby's way of saying, like, I'm done. I'm done. Older babies especially, they're better with their communication skills, so to speak. So any sort of turning away or arching back is just your baby's way of communicating and saying, I don't want to eat anymore. And I find with refluxy babies who are quite in tune with how their bellies are feeling, 4 months, and that's an interesting point too. So his turning away might just be his way of saying, you know what, Mom, I know that suckling, it's calming, it's soothing, it makes me feel good, but I don't want to fill up my belly any further. I don't want to eat. My appetite is satiated. I'm done now with feeding. I'm showing you that I still might want cuddles, but I don't necessarily want to eat. And around 4 months of age, feeding is not just reflexive as it is with a newborn. You know, when they have the root reflex, the suck reflex, you put something in their mouth, they suckle. Around 4 months of age, they're very much engaged feeders. If they don't want to eat, they're going to let you know. It's not just where before you could put your breast in their mouth and they would begin suckling. He's got his own personality now. He knows what he wants, he knows what he doesn't want, and he's just communicating that with you. And the most important thing is that you be respectful of those feeding cues. And if he's arching, if he's turning away, if he moves away from the breast and he seems comfortable, then that arching is just his way of communicating that for now he doesn't want to be on the breast. But you can still have lots of cuddles and snuggles. You're welcome. Any other questions? Oh, hold on, I see something here. How long does the mom need to cut out dairy in order to see a difference? It's usually a couple weeks. You know, it doesn't happen right away. Again, the proteins can still be within our system for a few weeks. So if we're doing a fairly strict cow's milk protein elimination, it's got to be 5 to 6 weeks. But this is another thing to remember, because I see it often. Moms are being told, okay, if we think there's a dairy sensitivity, cut out breast milk. No, that is not true. We always feed through the elimination. So unless in some situations, if the baby is quite ill, like during a hospitalization, we might do a gut rest for a couple of days or a week while we're kind of getting things organized. But typically we just say you feed through the elimination. So if mom's eliminating dairy, you still continue to feed through that elimination. There's no reason to interrupt breastfeeding or to stop providing breast milk to your baby while we're working through an allergy. Anybody else? Maybe not. If you guys think of any other questions or want to send me, a message privately afterwards, feel free. You can reach me obviously on Instagram, or you can email me at hello@nourishconsulting.net. Just so you know, I'm based out of Calgary, Alberta, so I do support breastfeeding families in Calgary and surrounding communities. I do travel out to Okotoks, to Cochrane, to Banff, all around the areas. So thank you all so much for joining. It was lovely to have you. I hope you learned something and something that can help either your practices or your breastfeeding relationship. So take care, guys. Have a wonderful Sunday. And my next live should be in a couple weeks, and we're going to be talking about dealing with too much milk or oversupply. Thanks so much. Take care. Bye-bye.